Okay, welcome to everybody to this new webinar promoted and broadcasted by ESTES. This evening topic is particularly tricky, from the most basic groin hernias to a complex incisional hernia. We frequently have to manage the reality of wall defects in an emergency. Acquiring insight from experts about indication and technique will significantly enhance our knowledge. This evening guests are Eva Barbosa from Portugal, Fernando Ferreira from Portugal too, and Gereon Lille from Germany. I leave the podium to Fernando or Eva. I don't understand exactly who starts, but anyway, it's not a problem.
Whoever you want, Diego.
Okay, the podium is yours, Eva.
Okay.
First come, first serve.
You must share the compartment of my. It is deactivated.
Oh. Now you can?
Let me see. Yes, now I can.
Okay, perfect.
Let me see where my desktop is. Thank you so much, Diego and ESTES, for inviting me to this webinar. And I'm thankful for being here, and I hope we can have a really nice discussion. Can you see my presentation now?
Actually, no.
It should be on.
Now the sharing has started. Okay, perfect.
It is? Okay.
Yeah.
You can see it? Okay. So let me just put this on another view so I don't have this in front of me. So what I'm going to talk about is the emergency management in abdominal defects in the open abdomen scenario.
Fernando, please stop to share your screen. Okay, go on. You have to share again the screen, Eva.
Okay. Let me see. Is it on? Is it on?
Yep, now it works. Okay.
So I'm going to talk about the open abdomen scenario and how can we deal with it. We all know by the guidelines that when managing open abdomen, most of the times a primarily abdominal wall closure can be achieved just with negative pressure wound therapy and horizontal mesh mediated traction, like in this case that was abdominal compartment syndrome of acute pancreatitis, and you can see the interface there, the sac that is covering the viscera. And we apply a mesh that is sutured to the aponeurosis, and we start traction early, not in the first abdominal wall visit, but very early we start doing the traction. And now you can see that we're going to close the fascia in a timely manner, maybe not all at once, but going from pieces to pieces to achieve final closure. But in some cases, and this is how it works, gradual approximation and closure of fascia, and then at the end, the mesh is taken out, and then we just close the skin. But in some cases, we cannot wait for gradual closure, or we cannot achieve it. So these are the cases that get out of these main patients that are very successful in a simple manner. And these are the patients that I'm going to talk about and show some cases and what to do in those specific complex cases. This is a patient in his 20s. He has ulcerative colitis, and because of that, he has liver failure. He's a child C. He's waiting for in a transplant waiting list, and his ulcerative colitis was not also very well. It was not efficiently managed, and he got a sigmoid perforation and a Fournier from that. So they went and did a total colectomy with the ileostomy, but I was called to the ICU because it was draining 3 liters from this wound you see here in the inguinal hernia. That was a communication between the intra-abdominal space and the inguinal hernia with the defect draining the ascites from there. And also when I opened up the abdomen, there was a complete evisceration, as you see here. So it was pretty much dying in the ICU with multiple organ failure, and they could not control neither the ascites, neither the patient, and he was about to die. So the only chance, you cannot wait to start traction and wait patiently because this patient is going to die soon. So the only chance was to close the disruption and close the abdominal wall in the most sealed possible way because he has ascites and is a very sick patient. And I always say, do not do component separation in open abdomen, and I mean it, but this was a special patient. We had to do something. So we had to have we have to treat the evisceration at the same time as treating the peritoneum for him not to leak from the inguinal hernia. So I did component separation, and so to have flaps to rebuild the peritoneum in the lower part and to seal it. And after that, we could manage to put a phasics mesh in there, more or less resistant to infection, not a synthetic mesh. And complete closure also of linea alba. Do not do not close the skin because of high risk of infection. So just put subcutaneous negative pressure wound therapy. And 1 week later, this was the case, and we could close the skin, and the patient was out in the ward. You can see here, so the skin is open, but the fascia is closed. So I closed the skin, and still you can see a little bit, this is sponge, white sponge, and we have a hole here that communicated to the phasics mesh. So there was a point here, this is bone, and here you have the femoral vessels passing. And so we had this hole here that was still a problem to deal. But anyway, no ascites leak, nothing. And the patient was in the ward. In the inguinal hernia, so we did the best. So you see here the skin closed and perfectly healed, no dehiscence here, but still we needed to cover this area that would otherwise would not be possible, and we had some exposure of the mesh here. So plastics just put a TLF graft, and this is the skin graft that also plastic have done, and they put it TLF here. And the patient actually, he did great for a while, but then his liver continued to fail, and the transplant team could not go in as he been like this, and he ended up dying a month after, and it was a shame for all the investment. But anyway, the abdomen got closed, and we could solve at least this problem. And in that part, there was a kind of success, although it's not happy that the patient could not survive due to his failing liver. Any other options for this case that were not so aggressive would, for instance, a biological mesh could be just put in there, or a vicryl mesh to seal the peritoneum. I just have, and this is something that we can discuss after, any other options not so aggressive. I have my thoughts, and maybe this was a kind of a shot, because even if you put like vicryl mesh to seal the peritoneum or biological mesh, you still have evisceration and situs coming, and I don't know if it would work just doing that, but it's something for us to discuss. Another clinical case for us to see how to deal with some complex open abdomens. This was a lady with a lot of comorbidities. He's a 3, 4, and she had a bowel resection after ischemia, and the anastomosis was okay, but then she had also a late total evisceration. And this was I got called to give an opinion on the open abdomen, and this was the retraction. And with this lady, she was really, it was not a patient that we could wait a long time, because it will be really bad for her. And if we would wait a long time to close the abdomen, and on the other hand, to do a planned ventral hernia, it was that kind of patient that we would never repair the hernia because she had such high comorbidities. So in this case, we decided for vertical fascial traction, and we applied it in the OR. That same day, the open abdomen was getting fixed, but not contaminated. And this is how the traction in the OR, the first time we put it. And then she went to the ICU with the traction. And just for, I don't know if it's what's going on here in my presentation. And after just one application during 4 days, total primary closure with just add minimum anterior component separation was achieved. And so in 4 days, we could close this open abdomen in a timely manner that she could not had such a bad outcome, as she had so many comorbidities. So we decided to add a prophylactic mesh in this case, because it was a high risk for dehiscence abdomen, but just put negative pressure wound therapy for better mesh integration before skin closure because of the risk of infection. That means that we applied the prophylactic mesh, put negative wound pressure, and then came back. And you can see here that you see a mesh totally integrated here, and then just close the skin, and she did very well. No wound infections. She had like 1 centimeter aseptic skin breakdown, and that was it. And she was out of the ICU and alive. On the other hand, not all cases can come so nice, and you have to have in mind that always there are some cases you cannot achieve closure, and this is one of the cases, a complication of abdominoplasty with bowel perforation, and it came to our center in like this. Of course, what you have to do, and the first thing that you have to do, is to assess what you have, and this is open abdomen is frozen. Also, you have skin ischemia, and this is not clean at all. So the first thing you have to do is septic control is essential. So we have to take all the stitches out, debridement, stoma rebuild, negative pressure wound therapy. And in this case, there's nothing you can do. You have to come back for another time for the battle. So you have to do a planned ventral hernia as soon as possible and just skin graft it. And this is the end of it. With the skin graft, the patient was alive. She went home. And this is 1 year after bowel continuity reconstruction first, because this was a double barrel ileostomy. And this was the day of the bowel reconstruction. And after bowel reconstruction, we had to start planning a hernia reconstruction. Lack of skin, so we put it skin expanders, botulinum toxin, and of course we had our plastic team in the OR at the same time prepared to do a flap repair if in case we needed, which was again probably that we would need it. Of course, we had very difficult adhesions in this case, but nothing occurred bad. We did not have to do any enterectomy or nothing. We did bilateral TAR, but still, as you see here, anterior fascia very apart. So we applied vertical fascial traction, and we measured to do midline closure with complete anterior fascial closure with rectus medialization. And this is 1 year post-op with a very functional abdomen, not as pretty as she would expect for a person that started this doing an abdominoplasty. But either way, she has a PT, she does her cardio, her muscle workout, and she's so happy that finally the nightmare is over. So sometimes you just need to do a planned ventral hernia and then come back another day and fix the patient in another day. With abdominal wall fasciitis, this was a patient of me and Fernando back then in the Hospital Pedro Spano. When you have these kind of patients, of course, you have to do debridement, hyperbaric therapy, negative pressure wound therapy. And if the patient survives to something like this, and you just have to worry about saving the patient, if it is possible, you just skin graft and leave the battle for another day. So in conclusion, management of the abdominal wall in open abdomen, most of the times a primary fascial closure is achievable with negative pressure wound therapy and horizontal mesh mediated fascial traction, but in more complex cases, abdominal wall reconstruction with component separation anterior or posterior may be value, but do it only if you know how and if there is not contraindications. Do not burn value abdominal wall reconstruction techniques, because that will be a disaster in the future if it fails. When there is lack of tissue, muscular fibers may be neither, but that's extremely particular cases. I do not advise it in the very sick patient unless you do not have any alternative, as you've seen in these patients. So it's not something that I advise. Vertical mesh mediated fascial traction can be a valuable tool in these patients, as you've seen in the patient that I've shown, and vertical mesh mediated traction can even avoid for you to do complex abdominal wall reconstruction, and we can also discuss that after in the questions. When you have frozen abdomen, loss of abdominal wall, stomas, fistulas that need future reconstructions, go for a planned ventral hernia and leave the battle for another day. And this is it. I'm going to interrupt my sharing and get back to you, Diogo.
Nice talk, Eva, as expected. It's very interesting how to manage different situation with different technique. I have at least two different questions for you. First of all, how you decide a different type of mesh for different situation? I mean, when you decide for synthetic mesh or biological mesh or biosynthetic mesh? This is my first question for you.
Yeah. In open abdomen, I never decide synthetic mesh unless it is after closure as prophylactic and with negative pressure wound therapy. Totally synthetic, like polypropylene, I never do that. I use synthetic mesh just for the traction, not for nothing else. Then I take it out because there is a high risk of infection. If I do prophylactic, after closure, if I do prophylactic, I do a macroporous polypropylene, but with negative pressure wound therapy on top. And only after that, close the skin. And there are nice papers about that. When I do more complex reconstructions in open abdomen, and I need a mesh for that, I use either biological, I used to do biologic, but now I do biosynthetic phasics, long-term observed, like a phasics mesh. If I need to do like an anterior component or posterior component or some kind of complex reconstruction.
Perfect. And the second question about the traction, maybe you all can answer me. When you decide for vertical traction instead horizontal traction, there is some advantage in one of or other traction in terms of results?
I think maybe Girian can talk about that a little more. I think that in cases that you see that the abdomen will close more or less easily and soon, we can use horizontal traction. It is cheaper, it is easy for everybody, it's accessible for everybody. If you have an open abdomen there, it's not going anywhere with the horizontal traction, or if you get them very late, or if you need to close them very fast, I think vertical traction adds value to that. That's my experience. It adds value. You get there faster. So I think we have to wait for the studies in the future to see if maybe we need to start it earlier or not. But I think in terms of benefit and not expensive, like in Portugal, we have to think about that. If I see that a patient is going to close pretty soon, I do it horizontal. If I think it's harder, I do vertical. I don't know the others.
It's a good answer. Garen, you have something to add? I think we have at least one question for the audience.
Well, I do actually. I would have one question. First of all, as I'm the founder of Faciotens, I just want to make that clear that I am biased. But I'm a surgeon, and I believe like all of our open abdomen should be closed as soon as possible. So I think we have to do whatever is necessary, and I completely agree, Eva, that we have to wait for good data. But like what I see in the last week, I was accompanying 3 open abdomens, that if you pull upwards, you can do it when you have still edema, and like these people all had a horizontal traction before in good clinics. So it is faster because in 2 days we won 6 centimeters. These patients had been open for more than a week. But coming back to the question I would have had is, did you apply Botox to the rectus when you placed Botox to this lady with the downside abdominal wall defect?
With which one?
The last one after the
Yes.
abdominoplasty.
Yes, it was difficult because of the skin expanders, but we could manage not the full dose that usually managed to, not to the rectus, to the lateral, we still could manage to have some spots that we could apply, not to the rectus.
Because it's just a question I would like to throw in. When we have transverse incisional hernias, I think what keeps us from getting together like in the transverse direction is the rectus. And I think we should consider more to also infiltrate the rectus, which I know many people are already doing.
Yes. Yes, you're right. We didn't do on this case, but we have to consider that in some patients that we think it may be value in this, because this was a transverse skin incision, but then the approach was vertical skin, so vertical fascia, not transverse fascia. So it's not like having a transverse complete, you know, that there is disrupts the rectus or everything. It's kind of a mixed.
Yes. horrible case.
You're right, but you're right. Yeah, horrible case, poor girl. But you're right. But what you were saying, Girion, I'm seeing too in the practice that with the vertical traction, it gets a lot faster. For instance, this lady, it was amazing because with only one application, we could close that huge defect. I would not expect that with horizontal traction, but we need data.
Yes.
Okay. And we have a question from the audience. Andrea Spotta is an Italian guy, but actually work in UK. Ask if do you use any negative pressure wound therapy with the installation? With the what type of results, or have any experience?
Yes, I use it when I have difficult septical cases to control. And in those cases, I tend to use the installation. So to get the burden of the bacteria, get it over faster in such a way. And I think it may add some value. Yes, so I use it in those cases with very heavy septic burden.
Okay, it's clear. And any experience of direct peritoneal resuscitation in a very septic case?
Not high experience. Yes, we've done it. Not high experience, just a few patients. And the patients started, then if I see that most of the patients, even with high burden septic patients, you can deal it with a couple of, revisions. But sometimes it's not just the septic, it's also the edema. And the edema, it can be the peritoneal resuscitation can also help in the edema, not just the septic burden. So if there is a lot of edema and septic, yes, I do peritoneal dialysis, and I think it works. It's hard to choose the cases, and it's hard to get data because it's hard to randomize patients.
Hmm?
But then again, I think it can be some value.
As you said, we need data about this
Yes,
case.
yes,
It's not easy to collect this type
not
of
easy.
data. And I have another question from the audience. When you use horizontal traction, what are the destiny of the mesh? You remove the
remove.
mesh or use it to stabilize the suture? Because
No,
this is two different type of school about that.
yes. When I do horizontal, I remove completely the mesh because that mesh was there for a long time. So if I want to do prophylactic mesh, I take that one out, I suture, close the aponeurose, then apply another mesh and do negative pressure. I don't stay with the same mesh.
Okay. Okay. Jaren, I have a question for you. About the vertical traction, I know that you are the father of this type of technique. Do you have some suggestion for the younger colleague about the proper indication about this relative new technique?
Yes. Well, it's hard because we're in a setting, you have to have it available. There's the cost of the system always. But like, why did I come to this idea? I did horizontal mesh mediated traction, and in many patients who still had edema, when I was pulling too hard, I had the problem that I had to reopen it because the intra-abdominal pressure went up. And if we have really, so I would say if you want to begin, it's really sick patients who need to be stabilized, because if you lower the intra-abdominal pressure, then you can you get a better organ perfusion, you get a cardiac preload, and you have a better ventilation situation. Or if you have these cases, like Eva said, that you cannot, that you see will come to your borders of closure with a horizontal mesh. So if I have a young person who's not intubated and he's fit, and he just has a problem of still too much swollen abdomen, and he tolerates it well, then do horizontal mesh-mediated traction. But if you have a septic patient, if you have someone where you're trying already for days to close it and it doesn't get closer, then I would change. But I think there's one very important thing Eva said. If you see that the closure might bring your patient into difficulties, then leave it. And I think it's very important to see if you have any adhesions to the abdominal wall from your organs, then please don't try to pull horizontally or vertically, because by both means, you will probably end up in a fistula. And that one will probably be lateral. And so you get into real problems. So then I think it's the right choice. If I come to open abdomen and have to give my opinion and I see I can't enter with my hand into the paracolic aisle of both sides, I don't do any traction.
Okay. This is a good message for the audience. Perfect. And another question about the preoperative pneumoperitoneum. It's not easy to organize this type of approach with the botulinum Botox injection, and personally, when I tried to organize in my hospital, every time I have to face some problem to set this type of approach. You organize the preperitoneal pneumoperitoneum in the same admission, or you plan the surgical procedure after the time needs to obtain the distension, the optimal distension.
Okay, so my protocol is when I have a loss of a hernia with loss of domain, I do. I have a consult. I have an like a outpatient clinic consult for do Botox. So imagine that, and now it has a huge. There's a lot of patients for that. So my next vacancy is next for imagine next March, I think. So we have a lot of patients. So imagine, so for when it gets to that appointment, I do Botox. And now I know I have to operate that hernia 4 weeks after. So I calculate the hernia sac volume and I multiply that by 3. Imagine that you have 1,000 and 2,000, and then multiply it by 3, it gives 6,000 of pneumo that you have to inject. If you want to do 1,000 a day, it means that I have to do it 6 days before the surgery. So after Botox, I say I'm going to operate on this day, 4 weeks from now. 6 days before, the rate, or 7 days, because I need sometimes with the radiology goes there, and with ultrasound or CT and fluoroscopy, it's the radiology. Now I have a protocol with them. They put the catheter in. And if the patient is a nice patient, very well oriented, and with a nice family, I discharge. This is an outpatient procedure. So he goes home and he injects. We teach them how to do it, and he injects the Botox every day, 1,000 or divided in 500, more 500 a day. And he has my number. If there's any problem, he contacts me. He goes also with DVT prophylaxis of enoxaparin every day, because with pneumo, there's a high chance of thrombosis. If the patient is not very well, I don't think he can do it at home, he does not have support, or is from very far away, because I receive patients from all over the country, I admit the patient into the ward and I do it in the ward. So I have to do it before he gets there.
Yeah,
I hope I I could answer to your question, Diego.
Yeah, you answer perfectly to my question. Okay, we try to fishing from the audience. Fernando, for some reason, is between the attendees, but neither. Oh my God. No. I can help him. I don't know if there is some way to send again the invitation. Eva, could you please send again to Fernando your invitation, because he
Okay,
is
I
not
will.
able to find your.
If you want to, Diego, I would have some slides to emergency vertical traction patients.
Go ahead.
Yeah. So I try to share. It's not much, but where is it?
Ok, tesoro mio. Quando ci vediamo?
Can you see this?
I said,
Ti lascio in pace.
Okay.
Sì, sì, sì.
Ayato, please mute your mic, please.
Ok.
So this is actually for patients who had a strangulated hernia with a loss of domain, or it was big hernias with a bowel obstruction, and that was done in Australia. And I asked Annette Wright if she could share some of the pictures, because she did all of those 4 cases. And as you can see, this is quite some. Why doesn't it move forward? You can see it's quite big defects, and you can see the obstruction. And here you can see as well a 16 centimeters hernia with a lot of loss of domain. And the idea of her was actually to not, or to do as less as possible traumatically. So she repaired these patients. It was 4 patients with M2 to M4 hernias. LOD was 5 to 50%. And she closed them with vertical traction, bringing the fascia together, and then just doing a reef stopper instead of doing a component separation. And all of them went home without any problems. So I hope Fernando is in now, because I didn't have more slides to show. I might find some
I
more.
don't see Fernando as well.
Is he
Hi.
in?
Can you see me?
Oh.
Okay. Welcome, Fernando.
Hi. Sorry, guys. I've been having some problems. I'm trying to share my screen now. And
We
Can you
see red nails. I hope there is not your.
it's my daughter's. It's
Sorry,
her
Diego.
computer.
I'm from Cologne. We are open people. Yeah. If Fernando wants to wear this, it's no problem.
It's all about inclusivity, you know.
Yes. Yeah, exactly. So my daughter saved me with her computer. I hope. Here we go. Looks like we're ready now.
Perfect.
Yeah. Let's minimize this.
The podium is yours.
Thank you. So sorry about this. You can hear me well, I hope. And so I'd like to thank you all for your patience. Sorry with these technical difficulties. And I thank Diego, Jonathan, Hayato, Zago, Alan, and Sasha for this educational event. It's a pleasure to be here and an honor also. And I also greet my fellow panelists, Jerian, Diego, and Eva. At the time we spoke about this, and the idea was to speak about emergency management of abdominal hernias. And well, I was not, going into the open abdomen, so Eva spoke about that. And of course, when we deal with the emergency management, a lot of times it's deciding what to do and not to do. So here are my disclosures, and the objectives of this talk is to speak about basically the basics of abdominal hernias, categorize them, how to assess them, and when we have to intervene, if we should intervene open or minimally invasive. I guess it depends on your expertise and what you can do, and of course on the patient physiology. Sometimes we have to contemporize, and we have to see if we can operate on the patient later on and try to get ideal events for the patient to come out well. But sometimes that is not possible at all because these patients are very ill. So with regards to the basics, I did a PubMed search on this, and with the words of emergency hernia repair or incarcerated hernia. And I looked at, high-level evidence. And over the last 10 years, I could only find 6 meta-analysis about this. So it makes sense. This is not easy to make stratified prospective studies at all. Most of the studies are retrospective. Some of them are controlled. And with regards to these 6 studies, I found at least just 2 of them which spoke about incarceration. One from Uli Dietz from Germany, and another one from the group of Michael Lang and Julie Holland out of Texas. So there's not much out there. And we go back to basics. That's what it's all about when you're treating these patients. You don't have to really know all the big classifications, because all these big classifications are very important, of course, if you want to practice science and to make things comparable and to make things understandable so we can all be speaking the same language. But above all, you have to know what you're dealing with. Are you dealing with an internal hernia or an external hernia? A lot of times we forget about these internal hernias. These internal hernias can either be primary with peritoneal defects or acquired owing to surgery. And a lot of times we also deal with external wall defects of the abdomen and pelvis. And these patients, we have to also see what's going on, if these are primary or also acquired owing to surgery. So when it comes to incarceration of a hernia, the patient can actually have a chronically incarcerated hernia. That's not necessarily an emergency, but sometimes these patients will have some pain and will have a partial occlusion, which will not show actually on X-ray early. It will show later on. And sometimes these patients will start to show then the strangulation later on, and especially when they start to have a compromise, of their vascular venous circulation, then their arterial circulation, then they start to suffer very much. So the problem is that a lot of times these patients are treated by secondary physicians, which I mean is not by surgeons. And they come to us with the diagnosis of a gastroenteritis, for example. But in reality, these patients will actually have had probably a chronic incarceration, and which has slowly become more obstructed. And on this day or 24 hours before, they've actually had an occlusion. So as Moshe Shine says, the important concept to be grasped is that as soon as the hernia becomes painful, tensed, and inflamed, you know that you're in trouble. That patient is in more trouble than you, of course, because that patient is a surgical emergency. So with regards to the internal hernias, they can be quite a few. We know from anatomically the hiatus of Winslow is a possibility. We also see a lot of times now these days more retrocolic hernias, and also retroanastomotic hernias, because we're dealing with more and more patients with the problem of obesity surgery and other surgeries. And a lot of patients would have Roux-en-Ys. They're going to have more of a chance of developing these type of hernias through these acquired defects. So as you can see, when you're searching for this, it's not easy to discover. A lot of times you have to know if the patient was in the clinical history, if they were operated or not beforehand, and also be suspicious of these possible internal hernias. It's very typical that these patients have unspecified pain. Their AST, ALT might rise a bit, and you look at the X-rays, you don't see much of anything, but then you order CT, and then sometimes you can only see major aspects of the CT, such as mesenteric venous ingurgitation or bowel all to a side when it's already too late. So these actually have a high mortality rate, and in the past they were registered as 2 to 9%, but I have no doubt at all in looking at the literature that we're reaching a double-digit percentages now of internal hernias in our practice. So the protrusion of this viscus through this primary congenital can also be in other areas, as you see here with the letters of D and E, which can be actually in the recess of the sigmoid or the recess of the cecum, and even in the duodenal recess. So as I said, which is much more common now, as you can see here, the internal hernias resulting from previous bariatric surgery or other procedures such as Roux-en-Y. And you can see that you have to be very suspicious. And when you're looking for this, it can be retrocolic or actually retromesenteric. And here's a case actually just this week where I was helping my colleague, Emmanuel Guerrero from CUF. We were called in to check on a patient that was in severe pain and gone various emergency departments, and diagnosis was not achieved. If you look at the X-ray, you can see actually not one but two swirls there of the bowel and the vessels. So it's pretty serious here. I'll go back just for you to see again. And here's a swirl right here of the inferior mesentery there, and you can see also over here also a swirl there. So these cases are dramatic, and this patient actually had a double passage through the mesenteric defect of the bowel, and then this usually in 75% of the cases has to do with the afferent jejunal segment. And as you can see here, this was it right there, and you could see here this patient with a terrible colored bowel and with ischemia, major ingurgitation of the mesenteric vessels here, and it was right to the limit. We managed to save the whole bowel. So again, we had to contemporize, wait a bit in the hour heat, wash out the patient. So we got things going, but luckily. And with regards to this, is that sorry, just wondering if you guys can hear me, because 1839, yeah, I think you can. So sorry, I got a message here and I thought you weren't hearing me. Anyway, with regards to the external hernias, so I've spoken about the internal hernias. The external hernias are the ones which we deal with the most also. And they can be midline, a lot of primary, umbilical, or epigastric. But of course, they can be acquired, and that's why we call them ventral. Ventral comes from ventralis in Latin, which means the anterior wall, where the majority of the incisions are. And we can find a lot of times that we also, major emergency, are inguinal hernias, which can be indirect in the majority of the cases. And of course, we find some femoral cases. So beware of the little old lady who is very slim, and you can't actually palpate anything, and they might have an obstruction which was not early detected, and you actually pass through some problems with a colleague discovers it the next day, and then on rounds they say, oh yeah, he missed it. So that can happen. So as I can as I'm saying, here's the little old lady, which you have to be careful with those crural hernias, which are not easy to palpate. So look at the history of these patients. As a former chief of staff used to say, the best prescription for a patient is a clinical history, a good clinical history, and a physical examination to see if the patient has or not any signs of obstruction. If you're looking at a patient that has more than 4 hours, there is no chance at all you should operate on the patient, because it is a very high risk to try and reduce the patient with more than 4 hours of abdominal pain, because that patient will have a high risk of ischemia or segmental ischemia. And so even if you reduce the bowel, it might perforate at a second stage. So we try a lot of times not to reduce the hernias. We should prioritize operating if the hernia is incarcerated. But there are situations where you have to operate, and that has happened to me also in the recent past, where the patient had problems with the private sector, and I tried to reduce the bowel. So, looking at less than 4 hours, looking at blood gases, X-ray, you have to do sequential exams and hopefully take care and see if the patient is or not fit, and the patient has reduced with no effort at all, the hernia back to the abdomen. When you're looking at other aspects where you can't reduce it or it's too high of a risk, you have to think of surgery. You have to consider, when are you going to operate on this patient? As soon as possible, of course, because every hour that goes by, more necrosis, more ischemia. Have to consider if you want a laparoscopic approach or not. A lot of times, some surgeons in the past have mentioned this. It depends on your expertise. We'll do an open approach, and then sometimes we'll put a laparoscope through the inguinal orifice, if that's the case. If you know how to do a good TAPP, that's a good option to approach this patient, for example, and look at the whole bowel and wash out the bowel. I've done that in the past and other techniques. Also, when we're looking at an IPOM plus, it is an option, but it's a getaway option. I sometimes leave that for more obese patients when I just want to resolve things and get away with it. But if there is contamination, I really hate doing an IPOM. It's not a good option at all, because you're going to have a chronic infection. Of course, look at what you want to do. If you have to use mesh, every case is a case-by-case basis. But more and more, you're looking at reabsorbable mesh, which is safer to use, and the prices are coming down. Antimicrobial prophylaxis, we've seen that in the past. If you're worried about anaerobes and colon, put in clindamycin or metronidazole in that, and also a third grade cephalosporin. With regards to this acute management, as I said, it is important to manage these hernias as soon as possible. Of course, we try to reduce them, and if we're lucky to reduce them, we try to contemporize, because we know that these patients, it's usually a one shot at them. And if you keep operating on them, and especially in emergency, you're going to find a 2 to 15 time fold increase, according to Julie Holohan and Michael Lang's group, of readmission and reoperation. Also looking at this systematic review of meta-analysis that was just put out in 2022 in surgical endoscopy, 37 studies. I found it amazing just to look that there's a 26-fold mortality rate from groin hernia repair. So we're looking at a very serious problem that if you're not careful, these patients will pay dearly with their lives. Looking also at another study out of Scandinavia, of Denmark, which has an excellent database, you can see that more and more the 30-day mortality rate is now rising again. Of course, the patients are getting older and they have less physiological reserve. And again, the 30-day admission rate, once again, is also rising. So, this is a problem which is paid dearly with their lives. Irrespective of any technique, we see a lot of minimally invasive surgery, people pushing for minimally invasive surgery, of course, also in emergency, and there's nothing against that, but you just have to keep with the fundamentals. And, just because you're doing something which is minimally invasive, you still have to do it as well or better as if you were doing it openly. So primary closure always, that's what we favor. And try to always get 4 or 5 centimeter overlap of mesh, so that if you have a movement of the mesh, you'll have less of a hernia recurrence. Try to diminish fixation with tackers, etc., because you know you're going to have chronic pain in these patients. And of course, we preferably go for sublay, but that's not mandatory. It depends on the patient's situation and what you have intraperitoneally. Also, and the situation of the posterior components. Minimally invasive surgery a lot of times is not feasible in those most extreme patients. But once again, case by case, look at it. And of course, we know it would be good to rehabilitate these patients, but these patients come into the OR and we have to take what we get. And of course, ARAS is the same thing. With regards to, contemporizing, if you can get these patients better optimized, even in the OR, we get them with fluid resuscitation. Do as much as you can. If these patients, if you can take care of the bowel, for example, some colleagues have spoken about small orifices, 2-3 centimeters, which are the higher incarceration rate, and where they just basically open up the fascia a bit and release the content. And if everything is okay, they leave the patient with a bigger abdominal hernia, and you can actually defer that patient in the same surgery, in the same admission. These are all options which are questionable. There's no hard evidence to support them, but again, this is a gamble, and you have to see what you can do. Even in the most experienced hands, you really have to be careful. So everything you choose, every way you go, you can make a mistake, no matter how experienced you are. You need good surgical judgment in every case. So usually what I like to do is, if you try to take care of these septic cases in one single stage, immediate, of course. But in more extreme cases, such as Eva has shown, you might have to delay it a bit. Of course, I always try to favor in the same admission, 5 to 10 days, and with infection control. And I've done that in the past and tried to do that successfully. Sometimes I've not been able to do it. It all depends on what you can do and what the physiologically, what will your patient take if you fail? If your patient is very ill and you see that they cannot take another failure, do not go for the same admission delayed treatment. Just get out of there, resolve the problem, the acute problem, and then leave it for a second stage after a few months when the patient is better and the patient is psychologically prepared for any possible failure, because yes, you can fail at that second try. Also, going forward, looking at obesity, which is a major epidemic all over the world, we're dealing more and more with these patients who come in and who are morbidly obese, and they have major hernias and incarcerated hernias. These really require a staged approach. You have to be very careful and try to save the bowel, try to patch up the defect if it's less than 2 centimeters, and or just patch it up with a mesh or with omentum, for example. Just try not to screw up things because these patients will pay dearly, again, with their lives. If a case of the patient, there is no contamination and they're morbidly obese, around 35, 34, 36, a small defect, and you can actually go for the possible correction, knowing that you have a little bit of a higher percentage rate of failure, but still you can go for it. This is the case of a patient with a sinus and they had an infected mesh. It was localized, but patient comes in with the incarceration, took out the mesh, left the hole, did it in a staged approach because the patient was well. I took care of that little bit of bowel, didn't go into the bowel. And after 4 or 5 days of negative pressure wound therapy with installation, I was able to close the patient and would put a reabsorbable mesh in. So again, that's a case. Also, looking at the literature, and this is a paper I just put out with Jose Bueno from Valencia, where we looked at 236 cases between hospitals in Portugal and Spain, it was possible to show that with high grades of contamination, there was no influence on recurrence of surgical site occurrences using reabsorbable mesh. So again, case by case, look at your degree of contamination, look at what your physiological reserve. It's all a gamble, but again, literature has shown it is a possibility. So you can use these types of mesh if you fear recurrence and infection. So these types of mesh can be an option. Comparatively to a synthetic mesh, of course, it is more expensive. So again, this is another case where I show an infection. This is actually after. It's a acute hernia because it's a patient that was operated initially, but then infected, so had to come in. And once again, we had to take care of the infection and not to destroy the previous mesh that was placed. So the patient actually had total destruction of the fascia, and we controlled that, and then got the mesh covered with a flap and negative wound pressure therapy and installation. Again, another long-term absorbable mesh. 8x8 was able to take care of this, and the patient is actually now 3 years, not 2 years. This is an old slide. 3 years down and no recurrence. So again, this is just to show a possibility of the use of these meshes if you fear contamination and, of course, recurrence. So the take-home message for me is that, for you, I hope, is that determine the chronicity of incarceration. Make sure this patient hasn't had various previous incarcerations. If it has, you have to operate on the patient. End of story. If you do ever consider a possibility to reduce the hernia, it has to be less than 4 hours, and you have to easily reduce the hernia. If not, consider surgery. Any signs of sepsis, operate on the patient. Don't take things for granted. Don't think that the patient will get better with fluids. Of course they will, but it will be a transient betterness, as we may call. With regards to primary versus mesh repair, always consider, again, your defect size. Always get the overlap of the mesh. Look at the location. Look at your patient physiological reserve. Your expertise will dictate the technique with the less harm for your patient. So, don't embark in the beautiful laparoscopic, minimally invasive hernia approach with a TAPP if you've only done 2 or 3. Just go in or normally, and you can do at the most put in a scope through the orifice of the inguinal hernia just to check to see if everything is okay with regards to your abdominal contents, the peritoneal contents, the bowel and itself. So things will get bad and ugly in emergency hernia management. Decide the best hernia technique. Just keep meticulous and stay strong and efficient, and things will turn out well. Thank you very much.
Thank you, Fernando, for your speech. Very interesting, very well done, with a very important message to the audience. In this situation, I used to say to my residents, better safe than sorry. So, I mean, it's better to manage the things in the safer ways possible instead searching something beautiful or something fashioned, because this situation can develop very easily in a nightmare. So it's better to stay with the feet on the ground and try to be very, very honest with the skills and try to do the best. Thank you, Fernando. Some other comments from the panelists. Welcome, Ayato, to join us. Very, very good to see you.
Sorry I was late, I'm still working here. It's nice to see Gary on Eva and Fernando. It's always a great pleasure. And we always learn a lot of things. Fernando, I have a question, Fernando. This is a bread and butter problem, right? It's I'm sure in this moment somewhere in Europe, some surgeon is managing strangulated or incarcerated wall defect hernia. But I think we should expand this knowledge? Do you think it's time to have uh, highly specialized people on this issue? Because I know there are a lot of disasters happening all over our countries, because this is something that the general surgeon dealing with emergency surgery sometimes underestimate the problem.
I think that things that may be ideal, and of course, if you have a subspecialization, it is always ideal. But in today's world, where patients are getting older and sicker, and the resources which we have were made for less population, and now we have a greater population, an increasing population, and of course a sicker population, it's impossible. That's what I feel. It's my opinion at the moment. So the best thing to do is what you're doing today. It's training people. It's giving them the possibility to see these webinars. And you know, there's no excuse in today's world, I think, that for information. People have so much access to information. What we're getting to a point is that some people are just don't care anymore. That's what I think. I think people are just looking more and more to, they're becoming tired. They want quality of life. But this, with regards to this type of surgery, you know, it's very nice if there's a highly specialized, minimally invasive surgeon who's on call in the emergency. Of course, they're lucky for that patient, but the majority of the times it's going to be surgeons who are in the beginning of their training, and they have to know, just as I mentioned, what to do to save that patient. And even if it's a bigger incision, okay, it is. And we know that we're going to have higher hernia recurrence rates, and then we're going to have the vicious cycle of hernias, as I mentioned. But it's impossible to this point.
What I think is that oh, sorry, Eva. You wanted to reply?
No, say Ayato, and then
No, go ahead, please. Go ahead.
I wanted to say something, because what I'm seeing actually two things. For instance, in the emergency room, the complex abdominal, incarcerated complex abdominal walls, abdominal hernia, the emergency surgeon gets a little afraid of intervening and tries sometimes to delay the treatment.
Yeah.
And I've seen some patients that I found out in the ward, like in the next day. And what I'm trying to tell them is that they need to face those patients like any other patient. If the patient has an emergency pathology to be intervened, they need to intervene. They cannot wait. They cannot be afraid of the complex abdominal wall, because that patient will die if they do not intervene, if they have ischemic bowel, if they, you know, if they tend to delay the treatment because they see this big hernia. And what they have to do is to treat what it's going to kill the patient. And what's going to kill the patient, it's going to be the sepsis. So even if they do not know how to treat that hernia, and it's not necessary actually, that just close the hernia sac wherever, you know, and then the abdominal complex, the hernia surgeons will deal with that patient later. Just save the life, do not delay the treatment. That's one thing. The other thing that sometimes I see is that because, you know, knowledge, like Fernando say, is now available for everybody, they, in the emergency surgery, they try to do a little more, but sometimes less is more. Never be afraid of leaving the final treatment for a later time. Sometimes it's better than doing the wrong treatment in the wrong time, and then things get a lot worse, you know? So it's not that I think you're right. Maybe it's time that involve like emergency surgeons, but the principles of not harming must always be on our minds. Of course, for instance, because my background is colorectal, so I had this lady a couple of months ago. She had inguinal hernia, incarcerated, and she had bowel ischemia. And because I'm a hernia surgeon and I also did colorectal, I could do everything minimal invasive. I did the enterectomy minimal invasive. I did anastomosis minimal invasive. I took the bowel for one of the trocar sites, you know, and I repaired the hernia minimal invasive. But because I did that, I have the expertise to do that. It's not wrong as doing any other way, as long as you do it with the same principles. You know, it's not wrong. So the main thing is not harming and not delaying treatment for someone who needs treatment just because you think it's a complex case and you're going to discuss tomorrow, because some patients cannot wait for tomorrow.
Because I think it's a very interesting discussion, because when I think about cases like that, I think about bile duct injury. If you're not working in a hepatobiliary unit, or you do not have a hepatobiliary unit in your hospital, and you have during a cholecystectomy, you have a bile duct injury, the literature is suggesting us just to leave it drain, close the trocars, and transfer the patient, you know. And I see some similarities here. You know, one option could be resect the bowel, get into a damage control mode, leave the abdomen open, do not touch the abdominal wall, and the following morning you might centralize. I think we should think about centralization of this patient. But on the acute setting, it's really very challenging, because in an elective scenario, you know, people know, most of the time they know where to go. They go to a specialized center.
Yes.
Maybe not on the first incisional hernia, but when it becomes complex, especially after a recurrence.
That's totally true. It's totally true, Ayato. I mean, it's just like I said in the presentation. If it's in the same admission or in a dual admission, and here in that case, as you said, it would be totally logical to try to treat the patient in the same admission with a deferred or 2 or 3 times, if necessary, treatments. But then again, if you see that the patient is not responding, you can say, okay, it's enough. What it matters is you're looking at the big picture and not just the little picture. And I think that's what we're all discussing here, the subspecialization and knowing what to do. So even if you're not subspecialized, as you know, Eva gave the example, there's always someone you can call. There's always someone you can contact. And that's the beauty of things. I mean, I've done that for years. Eva has done that, so have you. And we've all communicated. I mean, I recently spoke to a friend. I've done that in Australia and helped them out with a high output stoma. I mean, that's just the way it is. With today's communications, we have to take advantage.
But sorry, I think it's first of all to get rid of our egos.
Yes.
Yeah, because first of all, be humble. Today, I was in the surgery. I had a really sticky mesh. It was an 18 centimeters defect. Like there was a pro-grip inside. I couldn't get into my space redirectors. No way. What did I do? I went out and I called a colleague and I asked for help. And I said, how would you solve this? And you have to go to your colleagues and say, sorry, I just want to get a second opinion. The other thing is, go in open if you're not the biggest expert. If you have an emergency setting, you're not doing any harm. You can resect. You don't even have to do an anastomosis. You can leave it open, as you said. And to be honest, what is minimal invasive? Is it to cure a little hole in an abdominal wall in an elective setting with a ETAP or some laparoscopic or robotic approach? Or is it rather making a little bit of a cut and doing a preperitoneal mesh, and you leave the retrorector space okay and you close the gap above it? I think sometimes we lose the focus on which is maybe the bigger trauma. I would like to have, if I have a little hernia, I come to the one of you who's making me a little preperitoneal mesh and closes my defect. I don't want a mesh all over me, even if it's only 3 trocars.
That's true.
I think that we have covered for the vast majority all the interesting aspect of this very huge pathology. And I'm sure there will be much more to discuss, but unfortunately our time is running out. I will say thanks to all our guests and friends, Eva, Fernando, Gerion, Hayato, Andrea, Sasha, and all the people from the webinar team, and also to all attendees that stay with us until the end. I would like to remind you that ESTES will continue to offer training events such as this webinar, but also many other opportunities for discussion and growth. So the message is always the same: stay with us and stay with ESTES for the next webinar at the end of the summer. Bye-bye to everyone, and thanks.
Thanks a lot.
Can I just say
Thank you,
one thing?
guys.
One more thing, quick. Can I do really quick? I don't know if you're going to cut me off. I just had a question here, and someone said about incarceration. They just asked me, and I was just stating it's very important. It's not the incarceration itself, but it's actually the obstruction of the bowel. That's what I said. It's very important. As soon as you have incarceration and the contents of the bowel are compromised, and the bowel itself, the perfusion is compromised, you're going to have a rupture and peritonitis and severe sepsis and death. So just that was just a question someone said. Okay, take care of
Cherry over the cake.
Yes.
Thank you.
Thank you.
Bye-bye, guys.
Bye.
Have a good summertime.
Bye-bye.
You too.
Bye.